This is a different kind of presentation that I appreciate the opportunity to put together because I haven't really spoken about this, but this is sort of a recollection of the issues that the families that I have dealt with. And this is the stress of Graves' disease. So first, let me ask the parents of the kids with Graves' disease, what are the issues that you've been concerned about? Nicole. Behavioral outbursts? Okay. Other folks? Okay. Anything else? Your mother's talking about you. All right. She's on her iPhone. Of course she's distracted. All right. Sure. No, absolutely. From Colorado.
The indignation of being sick and wanting control over her own life and her own body and
right.
About it.
Yeah, it is really tough for kids when they start getting medicalized. It really is. Other issues? No. All right. So I think So these were some of the things that came to mind. We'll talk about some of these individually. So we heard about school performance, behavior, stamina in terms of exercise tolerance. Kids are so athletic these days that we see impacts there. Weight gain, which is one of the things we talked about in our focus group, and I'll talk about some of the recent studies that we've done in our group. And then actually some of the eye problems, which we've heard 2 sessions about already, and then we're going to hear from Dr. Douglas later on. And so let me talk briefly about school performance. So I would say if we have to pick one thing that really has been the herald sign of the kids that we've taken care of with Graves' disease, it's been the deterioration in their school performance before anything else really comes apparent. And of the boys and girls that we've taken care of, you can sort of time the onset of Graves' disease to the report card. There are some kids that will excel and they continue to get A's even though they're getting sick, but that is very unusual. When you get Graves' disease, it really interferes with a child's and an adult's ability to concentrate. And we see A students going to situations where kids are failing classes. And this other thing is something that we've noticed that nothing's been published on, but we find that even after kids are treated and their thyroid hormone levels are in perfect levels, perfect control, that you can actually see problems in academic performance for sometimes up to a year before they get back and achieve the same academic milestones that they were doing before. The other thing that we notice is, I think one of the reasons I feel one really needs to be very aggressive, particularly for the young kids with Graves' disease, is that these kids who get Graves' disease 2, 3, 4, 5 years of age, where it continues, that again we notice that even after everything is completely taken care of, we do find that a lot of the children, probably about 50% of the children, end up having difficulty in school going forward. So, there's something about Graves' disease which I think influences how the mind develops, and particularly for the young kids, I really think that we need to try to get these kids under good control. So in terms of what to do when these kids have Graves' disease, meetings with the school teachers, the guidance counselors, and let them know that the child cannot perform the way that the other kids in the class perform. And it's crazy these days with the amount of homework that kids are getting in school. In some situations, it's very much excessive. Part of this are parents' faults too, because parents think that if your child's not getting good enough homework, it means the school isn't good. And if parents are paying for education, you know, if the child only gets a half hour of homework a night or an hour, well, you know, I should be paying for more homework. And that, you know, it doesn't necessarily correlate. So we will send notes to the teachers and say no more than 15 to 20 minutes of homework a night because the child just can't do it. Reduce expectations. If your child has been an A student and has Graves' disease and drops down to a C student, that's okay. Physically and mentally, your child cannot do the work that they were doing before. So take it easy. Modified educational plans, IEPs, 529s, all kinds of different programs that schools have. And we often will recommend the guidance counselor meeting with the teachers to try to set up some of these things to actually reduce expectations. And then another thing, you know, if kids get Graves' disease while they're in high school, these are the grades which count when you're applying for college. It can really have an effect on somebody. So the typical child we see probably has had Graves' disease for at least 6 months before we see them. Their grades have fallen for probably 2 semesters. Then they get stabilized over the summer. Then they go back to school again. It can take them 6 months to sometimes a year before they get back on course. So up to 2 years out of somebody's high school career can be adversely affected by Graves' disease. And so I routinely write letters to guidance counselors, to college admissions committees that basically say that, you know, this child has had Graves' disease. I thought that the child had it for 6 months before I saw them, was stabilized. It can take a year afterwards for these individuals to get back in the saddle. So this is one I wrote back in August. I actually just wrote one 2 days ago for somebody who is who's a senior in high school at an academy in Rhode Island. So sometimes the admissions committees will look at this, sometimes they won't, but I can't emphasize enough the effect that Graves' disease can actually have on somebody's academic performance. Any questions about the school issues? So for some of you in the audience, have you dealt with this? Have you met with guidance counselors? Has there been sympathy, lack of sympathy? Yes. Yeah. Okay. Sure. What I can do is I can forward it. Actually, who's the webmaster?
That's me.
Oh, that's you. Okay. All right. Yeah, I'll send a copy of a few examples for this. Absolutely. The other thing too for the military service. So if somebody has been treated for Graves' disease and doesn't have a thyroid gland, because we have a lot of kids who actually want to go into the Army. It's a similar kind of thing. They look at academic performance, but one of the things that we find if somebody's on thyroxine every day, it ends up being a big problem. So we actually have to write a lot of letters to recruiting officers and say there are 1 million people in the United States on Synthroid, but it depends on the recruiting officer. Sometimes they'll say yes and sometimes no. Other comments about school? Yes?
What I did was I took the information with the symptoms off of the Graves' Disease Foundation website, printed that out, and we recently met with Hannah's guidance counselor and several of her teachers. And I mean, first thing I asked them was, do you know what Graves' disease is? Do you have an awareness of it or an understanding? Of course, none of them did. So it was an opportunity to really use that material and educate and really raise their awareness that it looks very much like ADHD, but it's not.
That's right.
So they were very appreciative of
Right.
that. I'm sure it'll help them in their career going forward.
Just about every high school in the United States will have a child who has diabetes, but Graves' disease is less common. So they're used to taking care of kids with diabetes, but for Graves' disease, it's often very foreign to them. All right, let's talk about behavior. So none of these are my kids, but 2 of the 3 could be. So So first of all, a few things, and those of you who have Graves' disease and parents of kids who have Graves' disease, these kids are exhausted. They're tired all the time. It's such a misconception that people think if you have Graves' disease, you're overactive and you have lots of energy. It's the complete opposite. These kids are tired all the time. They're falling asleep. They can't do their homework. They don't follow directions. Impulsivity is a big thing. Not learning to, the intrinsic clock that we all have, count to 10 before you say something rude to your mother or your father. It's, count to 1 millisecond. And so impulsiveness ends up being a problem. And then oppositional behavior. Other things? Yes. Is your daughter here? No, I'm just kidding. Yeah. Forgetfulness is a big thing. The only thing they remember is where they left their cell phone or their iPhone. And in terms of what to do, this is something that it really takes tolerance on the part of the parents and the part of the educator. I'm not aware of any medications or anything like this which are really going to overcome this. And then also, helping your child recognize that, honey, dear, you're acting this way because of your Graves' disease. It's not you. There's some kids I take care of, some teenagers. They say, I don't know why I'm acting this way. I don't know why I'm fighting with my parents all the time. And they don't like it, and neither do the parents. But again, recognizing that this is a symptom, of the condition. Other behavior issues that folks have seen? All right. Another thing I want to talk about is weight gain, which is something that that we talked about in our group. For the folks in the audience who've had Graves' disease, who have had issues with weight control after treatment for Graves' disease? Okay.
I just had treatment in general weight gain.
Okay. All right.
I'm in college, and this is me.
Where do you go to college?
Montana State University. I went back to school.
Montana State?
And I had enough first.
Oh.
The Office of Admissions, the Registrar's Office, race rage, and I went to court for disorderly conduct.
Can we turn off the camera? Oh, I'm sorry.
They didn't know what race was. They didn't know.
All right.
They didn't, and it's hard to explain that to people. It's
Right.
hard to explain that to your lawyer.
Wow. Okay. All right. No, it's true. I mean, we have all kinds of examples of this. When I was in Boston at Mass General, we had a kid that pulled a cop off his mounted horse in the Boston Commons. Anybody here who knows what Boston police, how they react? It wasn't with a smile. Yeah. So another issue, so in terms of weight gain, and this is actually something which is interesting. So we just published this paper just a month ago, which came out in Journal of Clinical Endocrinology and Metabolism. And what we did was we looked at more than 40 pediatric patients who followed with Graves' disease in whom we had weight data on for the 3 years before they had Graves' disease and then for the 3 years afterwards, where we took out all the other confounding features, other medications that they may have been on that may have influenced their weight. And one of the things that we actually noticed is, I'm not sure I have a pointer here, but it's hard to what we're looking at here, these bars over here, these are the average weight scores. And what we noticed was that over the 6 months that a patient is being treated for Graves' disease, whether it's by radioactive iodine, medical therapy, or surgery, we actually see a significant increase in body weight. And not only that, this weight gain persists afterward. And the amount of weight gain for the average child that we see in this period, it's about 15 pounds over the 6-month period. We've actually had some kids who've gained as much as 70 pounds over the 6-month period. Some don't gain weight. And this actually happens at a time when these boys and girls are still hyperthyroid, but their hyperthyroid state is improving. And so what we find is that about 30% of the children that we follow for Graves' disease actually will gain weight over the first 6 months of treatment, and then they keep this weight gain, and it doesn't go away. The group that we find at highest risk are girls more than boys, individuals who are overweight at presentation, and younger individuals more than older individuals. And again, this isn't due to the fact that individuals are being overtreated and they're being made hypothyroid. This is actually happening when most people are on the medications, the methimazole, and it's improving, but they are still hyperthyroid. As to why this happens, it's complicated. Individuals with Graves' disease and parents of kids with Graves' disease, you know that these kids sometimes have voracious appetites, and they eat. And it just takes a little amelioration of the hyperthyroid state that all of a sudden of burning off the calories end up being stored. So we now actually are more aggressive in terms of dietary counseling with the onset of treatment, whether it's radioactive iodine, surgery, or medical therapy. For parents in the room, many of you know this, but children take 1/3 of their calories in liquid form by what they drink. It's hard to put kids on a diet. So in terms of practical things which we do, so we recommend the elimination of all calorie-containing beverages. Milk should switch down to skim milk, a glass a day of that. Everything else should either be flavored waters, diet sodas, things like that. Elimination of sports drinks. Actually, Gatorade now, they now have a calorie-free preparation. Kids drink a lot of sports drinks. By switching from calorie-containing beverages to calorie-free beverages, the average child will save about 750 calories a day. About 2,000 calories equal 1 pound. So we talk about drinks. The second thing, in terms of snacks, when kids are watching TV, on the telephone, Xbox, GameCube, Wii, iPhones, iPads, all the other things they're doing, absolutely no eating or drinking or snacking, because the average child will consume between 500 and 1,000 calories a day when they're doing sedentary activities. And then for meals, try to trim back the carbohydrate-containing portions. And it's really difficult to have diets with kids, but by the sedentary activity restrictions, by changing the drinking patterns, you can actually have an impact. And this really can be a significant problem. So in terms of what to do, as I mentioned, we restrict the calories, and no eating or drinking with sedentary activities, and that can make a big difference. So the parents of kids where this is, how much of an issue has this been? I mean, how have you dealt with this?
I just like to say it's an issue for grown-ups, too. I can tell you that firsthand.
All right. Yeah, there have been some studies on this in adults that are older studies, and where similar things have been observed, and it really becomes a long-term struggle. So there must be some kind of reprogramming of the fat cells that happens during the hyperthyroid state, which continues to persist. So last topic, which we actually have heard a lot about before, happened to do with eye problems, and we've heard a lot about this. As I mentioned, the eye disease that kids with Graves' disease have, it first occurs less commonly than in adults and generally is less severe. But indeed we see this. We've heard a lot about what different presentations are. In terms of what to do, we tell parents really to be sure to keep an eye on their kids while they're sleeping, to make sure that we don't see the white part of the eye. We routinely work with ophthalmologists, eye drops, methylcellulose, a variety of other ones we heard touched on before. And our experience in that which has been published is that typically you will see improvement over time that we observe with definitive treatment. Following surgery, radioactive iodine therapy, using the hurdle ophthalmometer, working with ophthalmologists, we actually are following objective measurements of the proptosis. We usually do see improvement in these situations to actually help these kids down the road. So in terms of other issues, what are some other issues that have come up that you know, they like to comment on, discuss, things like that that have you know, caused stress for you or for your kids? Nothing. In terms of, oh yes.
Well, I have a question. I have children. Neither of them have radiation therapy, but they're very young, ages 3 and 5. And instead of the things that you listed as sort of things that you see in that sector, kind of normal for 3 and 5 years, are there key indicators for younger children?
Yeah. So first of all, it's really unusual to take Graves' disease at the younger ages, and often it ends up not being recognized for a while. So weight loss ends up being something that you can see. You know, as kids start getting skinny, the ribs, if the behavior really starts deteriorating markedly. The other thing that happens with Graves' disease, you have increased cardiac output, increased blood flow to the kidneys. Kids end up peeing a lot more than usual. It's unusual, even in the little kids, it's unusual to see a really big thyroid gland. It's unusual to see the eye disease. So, so I would say, you know, weight loss, behavioral issues, increased urinations, almost can be similar symptoms like diabetes. Another thing which I meant to comment on, actually, I see I didn't put the slides in terms of schools and sports. So many kids are involved in athletic activities. When you have Graves' disease, your exercise tolerance is really markedly limited. Some kids will fight through this, but often you'll see a decrease in exercise. We typically, if a child is really hyperthyroid right after diagnosis, we actually will restrict their physical activity, have them avoid being excessively active, because first of all, they aren't going to be competitive. Second, they aren't really going to feel that well. And so we also will write notes to the gym teachers to get kids out of gym class. Actually, I didn't realize how much kids hate gym. So, because when you write notes, they go, "Oh, can I have another one? Can you make it for a year?" That is something that we see. Yes.
At what numbers or what pulse rate, what are you using for markers for limiting physical exercise?
Yeah. So we like to. So in terms of the treatment, we like to see resting pulse rates under 100. So when a child comes in with presentation for Graves' disease, we typically start them on the anti-thyroid medications. Also, it's important to remember it takes a while for these anti-thyroid medications to work. High doses, low doses, it really takes about 2 or 3 months before the levels can drop in the normal range for 80% of individuals. So that means it's going to take even longer. So we will actually add a beta blocker on top of it, a long-acting beta blocker. We're fond of one called atenolol because it doesn't cross the blood-brain barrier and get into the brain and make individuals tired. You can do it once a day. And we have parents just check the heart rate in the morning and the evening to make sure it's less than 100 all the time. And kids can exercise on atenolol and or other beta blockers. So that's one of the things that and with doing that, that actually will help some of the symptoms actually start going away, because a lot of the symptoms are due to the racing heart, feeling like you have extra adrenaline on board. Yes?
Do you ever have children
Sure. Yeah. Right. Right. Yeah, so these are like the symptoms of a child who has attention deficit disorder or attention deficit hyperactivity disorder. And they can be almost indistinguishable from Graves' disease. About 40 to 50% of the time you see absolutely no eye findings in Graves' disease. In terms of thyroid size, probably about 40% of the time the kids do not have big thyroid glands which are picked up. And so we take care of a number of kids who come to us having been treated for Graves, who are being treated. They're on Ritalin, they're on Concerta, they're on Focalin, the medicine you can probably least tolerate when you're very hyperthyroid. And for children who have ADHD, who are being treated with it, it's now recommended that an EKG be performed on children before they go on these stimulant medications. And some individuals have also recommended that they also be screened for hyperthyroidism, particularly if there's a family history of such. And I agree with that, and particularly if you see somebody who was doing well in school, had good behavior, and then you start seeing a deterioration. That would be a situation that could be a herald sign of Graves' disease. That's right, because typically it's picked up earlier, but we take care of a number of kids. No. So they usually don't do it. And again, Graves' disease is really unusual in kids that young. So it's the group of kids who've been doing well in school, then almost starting to start developing these kinds of unusual behaviors that you would want to screen for. Other examples, we took care of a girl, came to see me for the first time in June, who had florid hyperthyroidism, big eye findings, a huge thyroid gland, and she had seen a sleep specialist because her parents noticed that when she was at night, she was sleeping very restlessly. And she was actually placed on Requip for restless leg syndrome. And, again, Graves' disease, 1 in 10,000 kids, something which happens uncommonly. And so these are situations where it's attributed to other kinds of situations. Most of the kids we take care of, we can probably say that we can date the onset of Graves' disease by a change in academic performance. It's at a minimum of 6 months. I would say it's going backwards. And if you look at the trips to the pediatrician's office, these kids have all been evaluated by pediatricians, have problems with guidance counselors, things like that, going back a while. So again, in medicine, we're guilty of this. We teach in caricatures. People with Graves' disease have a certain look to them. They have eye findings. They have a big thyroid gland. But that's not how most kids actually appear. Yes?
Do you know if there are any long-term studies that show that pediatric Graves actually changes anything with the makeup of the brain? Because there's an erratic behavior
Yep.
that even though there's thyroid doesn't necessarily seem to go away.
That's right. I agree with you, especially for the kids who get it at quite young ages. And this is actually something that we have been trying to study, but we haven't gotten those studies off the ground. So I'm, based on my experience in terms of how these kids have done academically later on, some kids repeating classes, difficulties that have happened, I am concerned that particularly the real young kids who get Graves' disease, that there potentially can be a lasting impact, which is why it's important that these kids really get treated properly and not be allowed to smolder as having subclinical hyperthyroidism long term.
I have a question about when you were talking about school and extreme fatigue.
Yeah.
What kind of findings, or how did you find that, and what does that mean exactly? Where does it come from in a hyperthyroid person?
Right.
And I'm extremely tired, and I just wonder, is it the stress of school? I mean, what do you think for
Yeah.
kids?
Yeah, I think it's really the stress of the Graves' disease, which can last for a while, even after things get completely normalized. We do, I see this with the kids then taken care of. That, sometimes and looking at the academic record in terms of report cards, it can sometimes take up to a year before the boys and girls say that they feel back to where they felt a couple of years earlier. I can't give you, what the exact mechanisms are. I can come up with all kinds of conjectures, but it's something that we routinely see, and this is why, if somebody gets Graves' disease, in high school, it can have effects that, for 2 years, 6 months before they're diagnosed, and then the 6 months it takes to get stabilized, and then the period of time afterwards. All right. Any other questions? Yes.
We were comparing in group of parents that these kids often seem to have really large tonsils and problems with tonsils. Do you think that's a reflection of the overall immune system, how it works, or have you noticed any correlation?
Yeah. That is not something that I've noticed in the kids that we've been following, that they appear to have larger tonsils or other enlarged lymph nodes, but that's just in the group of kids that we've seen. Yes, Dr. Wood. Yes. So, my experience has not been with the older kids, but the younger kids who've had Graves' disease. When you follow them long term, we do find they do have more problems, we do find that they do have more problems in school. Again, it may be the kind of referral base that we have, because we generally tend to see boys and girls that really have very complicated situations that the local endocrinologist may have difficulty dealing with, and they fly in to see us. But we keep in touch. We keep in touch with these kids, and we do hear, every few months, we hear updates from what's happening in different places, and hear about the kids who are struggling academically. And it's my impression it's really the younger kids who've had Graves' disease where this problem persists.
I studied that in adult families when I was trying to find out, and it tends to be in the boys that Graves' disease more in the girls. But we found out that there's more left-handedness in the boys and more learning difficulties in the boys, but they sure are in the girls luckily than the state without.
Yeah, thank you for that comment. Yes.
Executive who had never read a book in his life, and he was running King Oscar sardines, which then was a big company. And he also was the most decorated marine in the Second World War. So it doesn't mean they can't do stuff, but they maybe
If he didn't have Graves' disease, he may have caught salmon instead of sardines. Right. Yeah, so that's a good question. This is something which is routinely tested for, and the answer for that is no. It's not recommended that children have routine assessment of circulating thyroid hormone levels. except under certain circumstances. So again, children who have new onset ADHD syndromes, this is something that pediatricians should consider, that it can be due to hyperthyroidism, weight loss, intestinal problems, unusual clinical features. And again, most of the time when they're found to be abnormal, the pediatrician is really surprised because the symptoms can be so nonspecific and the child looks very different than actually how you look at the classic picture of a boy or girl who has Graves' disease. And again, this is our fault in the medical community for how we teach and the pictures that we present. We teach in exaggerated caricatures. We don't teach in terms of really what the kids really look like. So, all right, yes.
Along those lines, if we have Graves' disease and children do not, and we still get a baseline, you measurement, TSH, and some measurements, and just so that the important adults later on have some kind of measurement, is that something that is covered by insurance, or how would you go about that?
Sure, it should be covered by insurance. But I do want to bring up one other thing, and I see my time is up before we move on to the next speaker. For routine measurements of thyroid function, recognize that the range for TSH for kids is different than the range for adults. When you get labs done at Quest, LabCorp, even at Yale, it will say the range for TSH is between, let's say, 0.2 and 4. The upper limit of TSH for a child is 8. We get all kinds of referrals for kids coming in with a TSH of 5, 6, 6.2, 5, 5.5. That's within the normal range, and most pediatricians don't recognize that. Another hormone measure, T3, it actually goes up to higher in kids than adults. And then often pediatricians, they will measure thyroid antibodies, anti-thyroid antibodies. 5% of the population have anti-thyroid antibodies. Only a minority of that group will go on to get Graves' disease. So we actually find that when people are doing routine testing of thyroid function tests, it actually results in over-medicalization, misinterpretation of laboratory tests, and it results in kids having to have visits for when they're actually healthy, because pediatricians and the labs don't put on what the normal pediatric reference ranges are, and pediatricians don't know how to properly interpret these. And we actually find that probably up to 10 to 20% of our referrals are patients who have completely normal thyroid function tests, but they don't know how to interpret the TSH, or they checked off thyroid antibodies when they really shouldn't have done that. And this will be the last question.
So what would be the normal pediatric range for the T3 and T4?
Yeah, so upper level for total T3 is typically 200. And then for T4, it varies with the age. For example, a 2-month-old, so T4 floats around stuck onto carrier proteins, which vary. So for a 2-month-old, the upper range for a total T4 can be 22. Then it drops down, and then when puberty starts, when young ladies start producing estrogen, it can go up to 15, 16, 17. So, it really varies. That's why the TSH generally is going to be your most sensitive indicator, but they have to be interpreted along the lines of pediatric norms. So at this point, let me thank you again.